So crush injury, crush syndrome, and compartment syndrome. Again, Alden went over some of this in his extremity trauma lectures, so there's a little bit of revision. So a bit of anatomy, muscle bundles, these things are contained within fascia, which are these white parts, and they help separate muscle groups into their own compartments so that they don't interfere with each other and they can all engage with their own action. Fascia don't stretch, which is really important to understand going forward. So in a crush injury, it's exactly what it sounds like. An external crushing force compresses a muscle mass. And the pressure from the external force is higher than the pressure in the microvasculature that perfuses that muscle mass, and so blood can't get in and the muscle cells become ischemic. Now, we do this every time, you lean on a table, or we do it 100 times every day. If it's corrected quickly, there's no ischemia, and there's no problem. We think of crush injuries, and a lot of the data from crush injuries is out of earthquakes, but Australia is a very seismically stable country, and the most common cause of crush injury in Australia is actually just the compressive weight of a person's own body lying on a hard surface. So you can see this in very intoxicated people, and most commonly in the elderly who've had a fall, maybe on bathroom tiles or hardwood floor, and they don't get found for a couple of days and they don't move. And they can get quite large ischemic injuries over large parts of their body because of that. Now, compartment syndrome is related but different and distinct from crush injury. So the compartment syndrome refers to increased pressure in a muscle compartment from any cause. It doesn't have to be an external crushing force. Now, it can be, like I've listed here, you can have a crush injury, squashing it in, you can have a circumferential burn around the arm, which then starts to swell and crush everything in it. But you can also have internal pressure. That can be swelling from sprains or fractures, or a hemorrhage, bleeding within the compartment. That, just like a mass effect on the brain, will start to squash everything within it and raise the pressure within the compartment. Causes a problem of the microvasculature, not the arteries, not the big arteries, and it just stops those little arterioles from delivering blood as the pressure inside the compartment rises. Now, there's 5 P's in the textbook for compartment syndrome, but the first 2 I think are the most important because they're the ones that you might recognize early. So P for pain, it'll be severe and out of proportion to the injury. So someone at a footy or soccer game who's been kicked in the calf and is just complaining of excruciating, ongoing 10 out of 10 pain within the muscle there. It's a lot more pain than you'd expect from that sort of injury. You'd have to wonder if there's an internal bleed there starting to cause ischemia, and that's what is causing the pain. The other is paresthesia. So if the nerves get compressed, it'll cause tingling or burning. So as the pressure inside the compartment increases, it'll compress the nerves, and it feels exactly like pins and needles, which is every time you get pins and needles is because you've compressed your nerve. The more serious signs as we move down, the skin will start to look pale, long delayed cap refill. If it's in the leg, the foot may become paralyzed, and pulselessness is a very late sign. As I said, this is a problem with the microvasculature, not the big arteries. By the time it's affecting the big arteries and you're losing your distal pulse, you've got multiple compartments involved, and it's become very serious indeed. The muscle may also be noticeably hard, and you can just check that against the uninjured limb. If you feel someone's uninjured calf and it's soft, the other calf is like a rock, probably looking at a compartment syndrome. A little bit more on the differences. So a crush injury can result in a compartment syndrome if it involves the limb, that external compression force. But if we go back to that old person that I gave before in the example, if someone's been lying on the towels for 2 days, all of the skin and subcutaneous tissue that's been crushed under their body weight is going to have a crush injury, even though there's no actual muscle compartment in an extremity that's been compromised. It's just a very wide scale skin crush injury, but your skin is the largest organ in your body. And either of those can cause a crush syndrome. So this results when tissue has been ischemic, either that big injury like from the elderly person on the floor, or from a muscle compartment that's been compressed and is now ischemic, no blood flow, to the point where the cells have actually died. When they die, they release myoglobin, potassium, amongst other substances, but these are the ones we worry about. And while all that while all those toxic byproducts are contained, that's not a big problem. But once you move these patients, or you relieve the pressure, if someone is crushed by something and so you pull the thing off them, you then release those toxic byproducts back into the body. Now, the biggest problem for paramedics is the hyperkalemia. And if we have a look over at this ECG, early stages you'll see those peak T waves normally be much higher as well. Eventually the P wave will flatten before dropping, QRS will widen, eventually widen all the way into a sine wave, which is a pre-arrest rhythm. And also myoglobin is released, which gums up the kidneys and is toxic to the kidneys, will cause kidney failure if it's not managed properly. So the treatment for compartment syndrome is pretty medieval, but pretty effective. It's a procedure called a fasciotomy. If it's due to a burn, it's called an escherotomy. It's the same thing, it's just cutting the compartment open. Because the fascia can't stretch, that's the only way that you can relieve the pressure, cut them open and let them expand. The wound will just be kept clean and open until the pressure or whatever was causing the compartment syndrome has been corrected, and then they'll be stitched back up. So they'll have a pretty gnarly scar, but they'll keep their limb. Now, treatment for crush syndrome is a bit more complex. The big thing is to recognise when you're looking at the potential for crush. So, if you do have someone who's been entrapped by something for a long time, we're not talking 1 or 2 hours, we're talking more than 6 hours, or someone who's been, old person on the floor for a long time, they're very dehydrated, they're disorientated. When you lean down to have a look at the parts of them that are against the floor, you can see a lot of, bruising and blood pooling and that sort of thing. That's going to prompt you to worry about crush syndrome. So you get IV access, ideally large bore. On the elderly, that can be hard. And you want to get fluids running to protect the kidneys, also to dilute the blood. So if there is potassium released, it doesn't reach that toxic concentration. We're not talking 250 ml and check the lungs. We're just talking pretty large volume. So 20 ml per kilo straight up would be quite reasonable to get the kidneys flushing and get the blood diluted a bit. And you want to attach a CCP to these cases. So they have some hyperkalemic specific treatments like calcium gluconate, sodium bicarbonate, and nebulized salbutamol, which will all bring the potassium down. Now, if you do have someone who's got a, say, a crushed or entrapped limb, and and it's been there for a long time, a hiker's been trapped by a tree for a full day in the woods or something, you're going to need to make a decision about the potential for limb salvage versus the potential for a systemic, like a dysrhythmia from all the potassium returning once you remove that thing. So a limb can survive for up to 6 hours without any blood flow. And that's with a total loss of blood flow. So even if someone's got something crushing, say their leg, like a tree or a block from an earthquake or something, and they've been there for a long time, you want to be pretty sure that there's no collateral circulation and that the leg is well and truly unsalvageable. Because even if one artery is blocked or impeded, there may still be some collateral circulation prolonging the life of that limb. However, if you are sure from both the history taken in your examination that the limb is non-salvageable, and if they've been there for, a day or two, and there's just no blood flow, the leg just has no blood in it whatsoever, it would be appropriate to tourniquet off the leg, knowing that it is not salvageable. It's just going to be amputated, but at least you're keeping all those toxic byproducts down with the dead tissue then. As I said, a big call, but if you're confident, it is the right decision to do.